Hello, good afternoon. I want to welcome everyone to the webinar this afternoon. My counterparts from the National Council want to kick us off.
Hi, everybody. This is Libby Ethier. I just want to welcome you all to the webinar today. Virna and Jeff will be taking over momentarily. I just wanted to welcome you all and let you know that Joan King will also be joining shortly. Back to you, Virna.
Thank you. Good afternoon, everyone. Thank you so much for joining today. I'm really hoping that the webinar this afternoon can give you some foundational information and also give us an opportunity to answer any questions that you might have. So I know that it's often hard to unmute folks because we get some background noise or people forget and place us on hold. So I want to let you know that I will be looking at the chat box throughout the whole webinar, so feel free to put questions or comments in there, and I'll do my best to answer them and weave them in as we go along. And then I also promise to leave some time at the end for any questions that you might have at the end. So hopefully we will be able to talk about some of the things that are most pressing for you when we talk about sustainable behavioral health services. So before we get going and really get into the webinar, I have this information that we're required to show, so I want everyone to just take a second to read the information up on the screen, and then we'll continue to go. Okay, so thinking about what we're going to try to do today, so I know many of you are actively working on developing a sustainability plan for your behavioral health services, also thinking about performance indicators, particularly fiscal performance indicators, and we can talk a little bit about what those are, and then also really looking at optimizing systems to support sustainability. So I think that's an incredibly important piece, and we're going to be talking about that a lot as we go. So these are just a few of the objectives that we're going to try to address today during the webinar. And we are not able to advance the slides for some reason. I'm not sure why that is. Okay. So we're going to talk a little bit about, I always like to say the front end and the back end, and some of you may have seen these before. This is following my trip to Africa, so if you're wondering why you have elephants. And when we talk about the front end and the back end, we really talk about the front end of your business, your clinical care and delivery, your front desk operations, and then the back end where we really talk about your contracting, your revenue collecting, and all of those things that, if you want to say, sort of go on behind the scenes. So some of the things that we want to think about, so when you're thinking about a sustainability plan, you know, what are some things that you need to really take into consideration? So the first is staffing. Staffing is a huge piece, and we're going to talk about that a little bit. Who you staff with, when they staff, what that looks like is so important and so tied to revenue and to a sustainability plan. It really is something that is a huge piece. Productivity and volume. I always like to think about productivity and capacity as together, so we'll talk about both of those together. So direct revenue. Direct revenue I like to have you think of as dollars in the door. You know, I drop a bill, I get paid. So direct dollars in the door, things that you can really count on and predict. Indirect revenue are sort of those backdoor kinds of things. So maybe benefits that you get for having behavioral health or some sort of abstract revenue. Coding is an important piece, and coding more and more as we go forward is really starting to emerge as something that organizations really need to pay attention to. We'll spend some time talking about that. Contracting is really important, and not just as we move into value-based contracting and you know, all that brings with it in terms of contracting, but even just thinking about our contracts and making them a part of our sustainability plan. Optimization. How can we optimize our schedules? How can we optimize our documentation, such as with concurrent documentation? Thinking about back-end kinds of operations like denials. How are we getting denials? What do they look like? What are we getting denied for? And then dashboard development and really thinking, what do we need to know? What kind of information would we put on a dashboard as we think about sustainability and what that's going to look like? So when we think about necessary data points, right, we need to know what revenue, what we're bringing in, our expenses, how many visits, right? Certainly we need to be able to count the visits and our average reimbursement per visit. That's important, and it's important when you think about average reimbursement per visit to think about all of your payers. So a lot of times people will say, well, here's my average reimbursement, but maybe they don't count the individuals who don't have insurance. Or for you federally qualified health centers out there, often the average reimbursement per visit might not be taking into consideration any $330 that you got. So often that's a big discussion for your for the FQHCs. So do you know your cost per visit for behavioral health? This is an important data point, something that you should really know. Many times I hear from integrated care organizations, particularly those where behavioral health is at their primary visits, such as community health centers or medical organizations, and they might know their cost per visit, but it might not be specifically for behavioral health, which would have a different cost per visit than a medical visit. And your average reimbursement for behavioral health. And if you don't know these things, then these are things that you really should figure out and start to know. So if you don't know these things, then this would be a good place to start to really think about your sustainability or start the foundation of your sustainability plan. So we promised that we would talk about staffing. Probably the greatest variant in terms of what you can bill for and get paid and how much really varies with staffing. And particularly the licensure of the staff you're hiring that are going to be working in your program. We can share with folks a Montana sheet specific for billing for services, which has some different codes in it. We can certainly give you that information. And I would really encourage you to do your billing and reimbursement homework before you hire your staff. So many times we get contacted from organizations and say, I have this person, you know, they're not licensed, or they're a PsyD who is not eligible for licensure, or they're an LMHC or an LMFT, and I have a lot of Medicare patients, or I can't bill for those providers in my state. And so it's really important to think about the staffing. And many times organizations will hire individuals on grant funding, thinking, well, I'm not billing for these individuals and they're grant funded, but there, you know, always comes a time in our future when the grant funding goes away, and then you have a person that's been connected to your organization, and then, you know, what do you do? So I would really encourage people to think about staffing and sustainability right from the beginning. But staffing is certainly a big piece. And thinking about workflows. So I know many of you are part of integration projects, and often we ask you about workflows. What is your workflows, particularly if you're, you know, doing depression screening or other kinds of screenings, and we talk about your workflows. And there are all different kinds of workflows, and they can and should sort of vary by location. If you have more locations, you can always change them. But it's really important to think about your sustainability plan before you do your workflows. And I know myself and my friends from the National Council have worked on a lot of projects where we've done workflows but haven't done the sustainability, and then what happens is when you start to think about sustainability, then you often have to change the workflows. And so then I know many of you are familiar that you work really hard to develop workflows to get people to follow the workflows, and you post them around the site, and you have them as part of staff meetings. And then it's incredibly hard when you realize that you need to change the workflow because of a reimbursement or sustainability issue. You know, example, if you have Medicare patients and you can't bill directly and you might do some incident to billing or something like that, that's something that could change your workflow. And so you want to try to think about those things beforehand before you do your workflows. And that always makes life a little bit easier. And then, of course, you don't have to change it. It's really important to know your payer mix and really get a list of what payers your organization gets paid for behavioral health services, and really make a list of them. And also remember that many times payers have multiple products. And so you want to list each of them separately because sometimes they can be very different in what they cover or who they cover. And you really want to make sure that you review the guidelines for each of the payers so that you can see very specific pieces. So you want to really look at each payer and look at who do they pay for. So do they pay for LMHCs? Do they pay for social workers? There are many plans that don't recognize social workers that are just out of school until they're, licensed clinical social workers or have some other credential, and that can actually be a huge problem. There are some payers that even though a state might recognize an LMHC, they don't as payers. So you want to try to really make sure, you want to make a grid of all of your payers and all of your products, and then really look at the kinds of providers that they credential and reimburse for so that you can have a total list and that you can see where your gaps are. So that if you have a lot of patients that are from a certain payer, then you want to make sure that to think about that when you're doing your staffing. You also want to look for special payer programs, like if they pay for depression care as an example, or if you're doing medication-assisted treatment and they only reimburse certain providers for doing medication-assisted treatment. Or many times, as an example, they'll want those providers to be credentialed like a behavioral health provider instead of a primary care provider. And so there's a lot of nuances that you really want to pay attention to when you're putting your sustainability plan in place. And it's really helpful to go through each of your payers and really try to break that down. And what I try to do is I put it on a big grid, and I put all of my payers on the left, including all of the different products. And then I list all of my billable staff above. And then under each billable staff person, I list all the codes that they might potentially use. And then I go through all of the payers. And so it really helps you identify some of the holes that your organization has, or helps you plan for both staffing and then also plan to know what codes you might need to include in your contracts that maybe you use but that you don't see listed. And so that's a really helpful exercise in terms of really starting to think about sustainability and a sustainability plan. And we do have some samples of that. If you contact Joan, myself, or Jeff, we can certainly give you information on that and give you something that might be helpful. So thinking about contracts, so it is, thinking about contracts. A lot of times people will say, well, I got this contract in the mail for the organization, and my motto is everything is negotiable, even though people might tell me it's not. It's always helpful to call them up and say, listen, you don't list this provider, but is it possible to credential them or to reimburse for them in some way? Thinking about can there be another way that you're able to get paid? Thinking about, are there Medicare Advantage plans or other plans that you really want to try to pay attention to or contract with? And so you really want to try to look at your contracts and particularly look at the codes and the providers. So think about, does this list all of the providers that I need to use or I currently use? And does it list all of the codes that I use, plan to use, or currently use? And that's going to be a really helpful place to start when you're thinking about contracts. So when we think about coding, and we spend a lot more time talking about coding I think, than we used to. And for those of you who know me, I can talk about coding for a long time. But it's really important now to code what you do. And I really tell providers, I tell all providers that, but particularly if we're talking about behavioral health sustainability, code what you do. And you pretty much have a code for everything that you do. And some people say, well, why should I code for things that we can't bill for? So a really good example of that is case conferencing. So for the most part now, case conferencing, except for some very few exceptions and maybe some special needs plans or some other scenarios, is actually not reimbursable. And some of the codes have times to them, you know, maybe 30 minutes with the physician present or not, but there are actually codes that are not time-bound that you can use to indicate that there was a case conference with the primary care provider, a case conference with the psychiatrist, maybe with an outside source. And so your ability to use that code allows you to track the service that you're providing, so that you can go back to payers, you can go back to funders and say, hey, we don't get reimbursed for this, but look how much of it we did, right? It also, if you're coding for something, then you also give it a little extra importance, because many of us, you know, particularly in integrated settings, we like to go for that bumpability factor where I bump into you in the hallway and we have a conversation about a patient. It's really important to document that conversation in the medical record or in the chart, and so giving it a code often gives it some extra importance for staff to make sure that they document those conversations. So it's really important to code for what you do. Some other codes that, you know, are coming up a lot and are kind of fun to know. The 90839 is a crisis code, and why this has come up for many is that often as we're trying and playing a more critical role in keeping patients out of the hospital and doing some behavioral health stabilization, then this code is more indicative of a 60-minute therapy code. So this code actually has a 60-minute time frame, but is often more indicative of the services that we provide and differentiates it from a 60-minute therapy code. So many times what would happen is I might spend 60 minutes with someone that was in acute distress, maybe at risk for suicide, and I would code that as a 60-minute therapy visit. But actually that was a crisis visit, and we really do want to know how many crisis visits we provide, because that's often going to be an important piece when we're talking to payers or we're looking at the kinds of services that we provide. Also, many times the 60-minute therapy visits now with many payers require prior authorization, or they're giving a little bit of pushback around paying for them, some of the plans. And so now the 90839 is something that's more likely to get reimbursed. So if you're doing crisis visits, then that's certainly a code to use. The other fun ones that people are starting to use are 96127 and 96110, and these are kind of fun for folks in integrated settings. The 96127 is used a lot for the PHQ-9 and administration, and you can certainly look these codes up or get some additional information from Joan or the rest of us. And so what we found adding this code is, one, that it helps you with tracking to know how many times you use the PHQ-9. But also we're finding that many of the plans actually do reimburse for this code, and while it is not an amount of money that's going to send all of us rolling into the black, it might only be a couple of dollars per visit for the volume that we do some of the tools attached to this code. The other nice thing is that it's in addition to our regular rates, and so it's always nice. So it might be something to look at and to try. 96110 is for the developmental tools. So for those of you in integrated pediatric settings where you're doing ages and stages and MCHATs and those kinds of questionnaires for kids, and this is the code, or the Vanderbilt for ADD as an example. These are the code that's attached to that, and so that's often helpful to use, and also helps you to track the services that you're doing. There's codes for advanced directives. Many of us talk to patients about advanced directives, and having a conversation and then actually completing the advanced directives are two different codes. This is actually a quality measure for some plans. Screening for substances, this is one that comes up a lot. Particularly many of you are experting. And so there is actually a code, an H code that you can use for screening for substance use that you can attach to that screen, and that will help you report on it. So that's always helpful. And then also the social determinants, and we can send out a cheat sheet for people who would like. I should have put a copy in here. I think more and more it's important to code the social determinants as reason for visits and put them on the problem list, because it is helpful in a couple of ways. One is that if you're seeing a patient and they have food insecurity, whether you're looking at whether you're providing primary care or behavioral health, and you see that that patient has food insecurity, then you might want to follow up with them, or you might have a conversation about how it's impacting their physical or mental health. Same with homelessness, maybe somebody not having the ability to store medications. And so it's really helpful. It also helps you for reporting to say, hey, we care for patients that on the average have 2 or 3 social determinants. So we're really caring for a safety net population here. This is how we know, and that's actually helpful for funders and for your own knowledge. So I think it's important to code for some of the things that you're doing. Thinking about getting paid. So the thing about it is you can't really have a conversation about financial sustainability and not talk about seeing enough patients or productivity. I actually call it the P word. I don't use the P word. I think the minute you start talking to providers of any discipline about productivity, they hear wah, 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 and you don't care about my patients, you don't know how sick my patients are, you just want me to see more patients. And so I actually refer to it as access. And increasing the access that we have for patients. But at the end of the day, when you're thinking about a sustainability plan, is what I like to say, a big bad administrator, then the reality is that the productivity and the reimbursement and the number of patients is directly tied to the sustainability of that program. And so the idea is that the rate of productivity is really your number of billable visits, and not necessarily per hour. And one of the things that I kind of like to add here is that, more and more productivity is less helpful, for lack of a better word. And I like to think of how clinicians spend their day as a painting. And productivity is one color in the painting. And it's starting to be that productivity is less of a critical indicator for many disciplines, and that's because if we are specifically talking about behavioral health, we're talking about a behavioral health provider who might have a crisis visit, might do a warm handoff from a provider, might run a group, might see a 30-minute therapy visit, might check in on somebody who was in the waiting room that they made a referral for and was following up on. They might do a PHQ screening. And so all of those different visits have different time frames attached to them. And so if I say that that behavioral health provider should have 10 visits a day, they could theoretically do all of those things before noon and still have half of their day that's not occupied with patients. And so it becomes less and less, because you could have 5 people in a group. You could do 3 10-minute warm handoffs, and you've already seen 8 patients, which looks like a lot of productivity, but isn't actually reflective of how someone is spending their entire day. And then thinking about capacity, which is actually the time spent that you're working face-to-face with patients or in direct patient care activities, right? And so the idea at the end of the day is that you need to have enough of those visits to be able to be sustainable. So thinking that what you're looking at is the number of face-to-face time spent with patients, and then the total time that people have available for patient care. And so what generally we think about as a benchmark is that people are spending 80% of their time in sort of those direct care services, and then 20% of their time doing those non-direct kinds of services, which is the case conferencing, the telephonic follow-up, the treatment plan, some of the charting not done in collaborative documentation, supervision, and some of those other pieces. And so looking at both productivity, the number of people seen, and then capacity, really helps you to paint a picture of what clinicians are doing during their day. And so I encourage you to really think about, and there's some tools out there to really map out, what you need that to look like, and how it should look like. And generally, if you think about an 80% capacity, so I really encourage providers to not block administrative time or to do some of those things to really make sure that we have access to patients, but that if you watch a clinician's productivity and capacity, then you have a really good sense of where they are. So if someone is at 95% capacity and 100% productivity, or 95 or 100% productivity, then that's somebody who probably is maybe getting a little bit behind and might need some support. Somebody who's maybe at 110% productivity but at 50% capacity is the person who's seeing a lot of patients but for shorter kinds of visits, and so they still actually do have some time available for other patient care activities. And so that's really helpful. And clinicians know, I know that in my system I really do look at that, and I make an effort to reach out to the people that I think might need some support, and also to follow up with the people to say, hey, your productivity and or your capacity, it seems like you have some capacity. We have a whole community of people that really need you. How can we figure out how they can access you during the time that you have available? And really looking at their capacity with them. So we can certainly talk about this a little bit more as we talk about some of the scheduling optimization, but this just gives you sort of a 10,000-foot overview of things that you can do a deep dive into when you do your sustainability plans. So thinking about credentialing, this comes up often during sustainability discussions, and if I had to say the #1 way that many practices open a window and throw money out, it has to do over credentialing. And so credentialing is not to be confused with professional appointment, although those terms are sometimes used interchangeably. But a lot of times what happens is the credentialing process, if an organization is just starting behavioral health services, then they need to figure out how to credential them with all of the plans that they participate with. Maybe they have to add them on the contract or get an addendum. And this process can take a long time. And even if they are familiar with the plans and with that process and credentialing, behavioral health providers, process can take a really long time. And so I would think about some ways in your system to try to minimize credentialing lost revenue. So one is, once someone makes a commitment to join your organization, while they're going through the professional appointment process and giving this to another employer, that you actually have them do the credentialing paperwork so that when they start and begin to see patients, they're listed in at least some of the plans. That you think about delegated credentialing, that you work with the plans to say, hey, we have a pretty good process in place. Is there any way you would, consider delegated credentialing, which means that they sort of accept your credentialing process, and that you can give them a file of new providers without having to submit individual applications. Also talking to your plans about having a covering provider, or thinking about what that looks like. And so there's a lot of guidelines around that in terms of disciplines and making sure you keep that the same, and that that person would be a billable provider with that plan. So there's certainly some things to think about and some guidelines, and we can certainly answer some questions around that. I think we'd be certainly glad to do that. So thinking about abstract dollars, a lot of times people ask me, I know many of you are doing impact collaborative care depression work. Often that is tied to abstract dollars in terms of reducing time spent with the primary care provider or increasing the number of appointments that patients might keep as their depression symptoms are reduced. Thinking about your rates for PCP or particularly specialty care. Oftentimes if you have a complement of services, then patients are more likely, and getting care, they're more likely to keep other appointments, be adherent to medication, decreasing your emergency room utilization and visits. So, you know, there's a whole lot of ways to think about abstract dollars. The thing about abstract dollars is they're not measurable, but they certainly are worth noting, places where you think you might have some abstract revenue in your sustainability plan. I also think about now quality dollars. More and more we're thinking about, you know, what does this look like? So thinking about, is there potential to have care management paid for at your site? Thinking about if we keep people out of the emergency room by doing some, you know, behavioral health stabilization. You know, if you give us our high-cost patients and then we manage them with all of our disciplines, is their ability to share in some of that savings? So that's something you want to try to do. And often if you think you do something really well, like you do really great transdisciplinary care with your prenatal patients, or, you know, with a certain population, then offer to be a pilot and say, hey, we think we do a good job here compared to other folks. You know, can we really look at this and think about, or if you can give us the information on the patients that cost the most money or who have been in the emergency room many times, those are opportunities to see if you can put some systems in place to be able to reduce some of that utilization and get some quality dollars. And often, since we're specifically talking about behavioral health, you can do little things like in the intakes that all of us behavioral health providers love. You can ask questions in there about, often we ask about mental health hospitalizations, but we don't ask about emergency room. And so even just asking the question, so how many times have you been in the emergency room in the last 6 months or in the last year, and then really addressing that. And so those are just some thoughts about quality dollars. So I think in a little bit of a summary, thinking about starting to optimize some of your services, knowing what you should get paid for all services. So a lot of times, just for fun, I'll pull payments from one particular payer and I'll say, okay, it says in the contract that they're going to pay me $75 a visit. I'll go back and look, because sometimes what I find is I'm not actually getting paid $75 a visit. And maybe they have a reason why, and maybe it's a good reason why, but more often than not, it's not. And so unless you do that kind of review, you're not going to catch some of those things. Also thinking about workflows and opportunities to upcode. So I know upcode is a bad word, but thinking about the time and complexity of visits, particularly if multiple people are involved, and making sure that you're coding appropriately for those kinds of visits. So reviewing same-day billing and services, you know, what are you doing same day? Certainly we don't want patients to make extra trips, but there are ways to optimize and look at what that looks. Thinking about different diagnoses for same-day visits. So I worked with a clinic recently, and they actually didn't get paid for same-day services from Medicaid in that state, but they actually did from their third-party payers and from Medicare, but they didn't realize that if a primary care provider saw a patient and they scored for depression, and then they did a warm handoff, and then the behavioral health provider saw them, that if they both listed depression as the primary reason for visit, that they were less likely to get paid, but that if the primary care provider talked about other primary care issues and didn't make depression the primary diagnosis, then they would get paid for both of those visits. Another thing to keep in mind is payers are starting to balk at the not otherwise specified, or the NOS diagnoses, so like depression NOS or anxiety NOS, and starting to think about being much more specific, which you should really in your diagnosis. But also there's opportunities, particularly with Medicare and some others, where using a different diagnosis that is a little more comprehensive can actually change the reimbursement. So it's a good practice to do. And a lot of times people also ask about Medicare in particular, and they do actually pay for the 2 visits on the same day. You can incident 2 visits for some providers like LMSWs who are not directly billable to Medicare. It's a little bit more of a complicated workflow, but thinking about putting that process in place. So you do have to follow the Incident 2 guidelines. We can send them, or Medicare has them online. Thinking about depression screenings, thinking about form completion. There are certainly the new Medicare codes out there now for collaborative care. The G codes are out there. Unfortunately, federally qualified health centers are not able to bill for those codes, but other centers are. And there's also the chronic care management codes that many individuals, organizations are using to help provide some care coordination services to Medicare beneficiaries with a chronic illness. So thinking about getting paid what we're due. So again, I talked about making sure all the payments are correct, and also denials. Denials are so important to look at because many times we're getting denials for things that are really avoidable. And I've been in so many places where the clinicians who are providing the care have no idea that there's a particular code or that they're doing something that is not reimbursable. For example, maybe they're putting obesity as the primary problem or primary diagnosis, and the payers are seeing that as a medical diagnosis and not paying that for a behavioral health provider. So sometimes psychiatry prescribers and others might, do that. So oftentimes I'll tell organizations, pull out your denials, let's look at them, and oftentimes there's some on there that, given the clinician's information, that's incredibly helpful. It's also helpful to get a sense of what a benchmark should be. So you really should be getting paid for at least 90% of the claims that you're billing out the door to be able to get paid. So anything less than that, you really want to think about, why are we not getting paid for them? What are we getting denied for? What does that look like? And then really looking at your payer contracts and thinking about that. Looking at self-pay, so what your sliding fees are. If you offer multiple services, you need a different sliding fee for behavioral health. Often FQHCs ask me, do we have to have a different, what does HRSA say? Do we have to have a different sliding fee scale for behavioral health? The answer is no. You certainly can. You might also think about bundling things like, 4 visits and a group every month in sort of a bundled rate. So where there are different things that you can do that are creative for your sliding fee or for your uninsured patients. So thinking about reviewing your charges, thinking about getting on your notifications for your state Medicaid. There's all kinds of things that I wouldn't know about unless I skim through that Medicaid provider update. So there's a lot of things in there that might not apply, but every once in a while they slip something in there that's kind of important to what you do. So I would definitely encourage you to look at it. So at the end here, what are we really trying to do? We're trying to operate fiscally sustainable clinics that are efficient about resources and patient care. And I think that's some of what we've been talking about, and more specifically, starting to quantify what efficiency looks like. So we talked a lot about face-to-face time and counting visits and the total time available for patient care. And we really want to try to look at these things in a very different way, and thinking about how we can make our things more efficient, particularly to make sure that we're operating at a surplus, that we're certainly not at a break-even point where our revenues are equaling our expenses, but that we're actually running our behavioral health services in the black, and looking at the necessary data points to do that. So what are our revenues? What are our expenses? How can we count our visits accurately? And again, knowing our average reimbursement rate per visit. And that's incredibly important to be able to calculate this out. I won't go into this, but looking here a little bit about what some of the necessary data is to understand what your expenses are and what some of your break-even points are. So here's your salary with your benefits and then your administrative overhead. And then also what your reimbursement is, how many visits you might know to break even. And that's an important piece. So it's important to know how many billable visits do we need to break even. And the other thing to remember is even on a perfect day, we're not going to get paid for every visit. so that if we decide we need 1,693 visits to break even, we have to look at what percentage of visits we're actually getting paid for and use that. So if we're only getting paid for 90% of our visits, then we need to have more than 1,693 in order to break even. So that's just something to think about as you do this work. And then thinking about enhancing efficiency in terms of scheduling. One of the biggest ways that organizations, particularly in behavioral health, lose revenue and efficiency is because of scheduling. And there's a couple of pieces. One is that they schedule appointments too far out, so that if I'm a behavioral health patient and I get referred, a warm handoff, or I call in, oftentimes I don't get scheduled out for maybe 2 or 3 weeks, sometimes more. And every day that goes by is a greater percentage that I'm not going to come in. And then what happens is you have a typically longer intake slot that remains open. Oftentimes people will talk to me about a gold standard, and I always tell them the gold standard is same day, next day scheduling for lots of reasons. One is because we want to get people in. We don't know how at risk they are. And also people often are seeking episodic care. They hurt and they need care where 6 weeks from now they might be in a different situation. The other is in terms of no-show rates. So oftentimes people will tell me, well, our no-show rate is 20% or 10%. And I say, well, actually, you know, I think of that sort of the same way, that that's actually only a color in the painting that talks about what our open slots are. And so what I mean by that is you can have a 10% no-show rate, but you can have a 30% cancellation rate. So to me, it doesn't necessarily matter in some ways whether they canceled or you canceled or they no-showed or you no-showed. What matters is at the end of the day, you had an open slot and you can't treat a seat. And those open slots are what really adds up. And so many times we see that providers will say, well, my schedule is full. I can't schedule anyone else. My schedule is full. But if you look at their schedule from the day before, you'll actually see that they had a significant number of open slots because of no-shows or cancellations or whatever the case may be. And so one of the most enlightening things that a behavioral health manager can do is actually sit down and review what the open slots are. And so looking at the open slots and actually counting them. So I like to, you know, sit down and actually do it manually because many times systems can't. And I'll get a cup of coffee with a behavioral health manager and I'll sit down and we'll literally go provider by provider and they'll say, okay, Monday 10 a.m., 11:15, 12:45, 5:15, and I'll make little knots, you know, notches on a piece of paper. And at the end of the day, the end of the week, the end of the month, we count up how many open slots there were by provider, by site, and often that is a considerably high number. And if we multiply that by your average reimbursement per visit, it's a considerably high number. So you're never going to have your entire schedule packed full, more than likely. You know, you're still going to have the ability to have an 80% capacity where you have some give there, but you do really want to try to get to that point. And you want to try to think about some performance indicators around your scheduling, right? So when was the appointment made and when did they actually get an appointment? And thinking about what the outcome was. So often you want to try to, you know, look at consistency in terms of defining what a cancellation is and what is a no-show. So a lot of times we'll ask organizations, and different centers might have a different process. Well, if they call the same day, then that's a no-show. If they call the day before, then it's a cancellation. And so you really want to try to have some consistency, although at the end of the day, what really matters is that you had an open slot. And this is actually what I try to do, is I try to look at what open slots are and mark them. And so literally highlight them and see what days have open slots, and then see how many there were in total for the month. And I actually worked with an organization in Montana, sat down with the behavioral health director who had several behavioral health providers in an integrated setting, counted up the open slots, and realized that they had 157 open slots across their few clinicians during the course of a month, and then set out to try to figure out how they could create additional access for patients and eliminate that number. And there's a couple of ways to do it. I always like to say that, you know, our patients tell us what we need to know to be able to optimize our schedule. And so if people are not coming in for initial appointments, are we scheduling them too far out? If people are not coming in for second appointments, what's happening during the first appointment? Maybe we're doing a long intake and maybe we should do more of an engagement. If people are dropping off and the average length of care is maybe 6 weeks or 8 weeks, which you often see, or people start coming just enough to hold their slot, then people are wanting episodic care and maybe doing something like 30-day action plans. So there's lots of different solutions sort of based on what your information tells you. But one of the things to really think about is to do sort of what's called hotspotting and to really get to know what your schedule is so that you can look and say, okay, on Tuesdays, we always have open slots at 10 a.m. On Wednesday, we always have one at 11. Thursday is a day when we generally have multiple open slots, and create a shadow schedule so that you can give people same-day, next-day appointments and then slide them into open slots as they happen in your practice. So you do actually get good at that. That's one process that organizations use to try to fix, you know, or address scheduling efficiencies and get people in same day, next day. And really thinking about, you know, benchmarking. So what is your ideal, you know, number of days out? Again, the gold standard is really, you know, scheduling same day, next day. And particularly in integrated care settings, it's so important to be able to do warm handoffs and get people into care right away. And a warm handoff can be, you know, 3 to 5 minutes, or it can be a longer visit sort of based on whether or not somebody is with the patient or there's somebody available to see that person. But you really want to look at defining some of these, you know, days out. And you really want to try to get good at predicting your no-shows or your cancellations, thinking about strategic overbooking them. And also, even if you say, wow, this sounds like a lot to take on, then you can do some very simple fixes in your system. For example, if you have a cancellation, so if I call and I cancel my appointment for this afternoon or for tomorrow morning, then you instruct your people to call people who have, you know, maybe new appointments scheduled next week or even farther, and offer them the appointments that just opened up, so that you're taking people that are farther out and moving them in as opposed to just leaving that cancellation an open slot. The other thing that you can do is you can change your dialogue with your front desk folks, so that if I call on Monday and I say, you know, I'm canceling my appointment with Jeff this afternoon at 3 o'clock, rather than say to that patient, okay, we'll see you next Monday at 3, say, well, you know, Jeff has an opening on Wednesday and he has an opening on Thursday, you know, would you like one of those appointments? And so patients will get used to that. And thinking about, you know, those two little changes often can make a difference. But you will get really good at identifying days with open slots and sort of doing this hot spotting. And so thinking about decreasing these days out. The other thing is to consider walk-in services. So one of the things that a lot of organizations are doing is, particularly for medication management with psychiatric prescribers, is having them just come in on an open access. So what that does is it kind of takes away from front desk having to call, remind people of appointments. It takes away from all of those phone calls that say, I know I was supposed to come in Tuesday, but I'm out of meds. and them getting stuffed into a schedule that when the provider walks in is completely packed with people, and gives people the ability to walk in during the week that they're running out of medications. And as long as you can track to see who didn't come in so nobody falls off the radar, often it is just a much easier process for organizations. And also maybe thinking about open access in a very different way, and thinking about doing two things. One is really quick access. So how many times can you turn intake slots into something else, and how many people can you take on any given day? Maybe you're not blocking intakes as longer sessions, but shorter engagement sessions and bringing someone back. Knowing what your average length of treatment is so that you can maybe do something different with patients and step people down. One of the things to really think about is using the data to tell your story. So if you're looking at people who are missing sessions, and a lot of times I like to weave this into supervision to look at patients that haven't kept appointments in the last couple of sessions or in the last week, and then look at their attendance and then talk to clinicians about revisiting a plan to step that person down to biweekly or into a group. So you really should have some diversity and not have everyone in sort of weekly treatment, but people should be in varying levels of treatment across your system. A lot of times people ask about open access as part of a sustainability plan, and open access is a lot of fun to do. You just really have to think about it. Often it's best to start with one provider. So example, one psychiatric prescriber as an example might be a way to start and figure it out a little bit in your system. Also thinking about one population. So are there people that you can identify who have missed more than 50% of their appointments, and maybe they get moved into open access where you say, it seems like it's difficult for you to come in, at a designated time. Transportation is an issue for you, child care is an issue for you, and so, perhaps it might be more helpful for you. Here's some open access times during the week that you're able to come in and see me. And so that's often helpful, and then that will also change the number of people who are not coming in or who have no-show or canceled appointments. So as you think about sustainability and think about, developing your dashboard, we've sort of touched on a lot of different considerations. Think about where some of your biggest holes are. Do we have a big problem with denials or credentialing? Is our schedule really a problem, right, as an example? That actually might be something to take into consideration. And then also thinking about what information would we need to be able to do this? How would we get this information, right? Who would give this information to me? How would I get it? And I think that's some important pieces to really start. So I like to say, what do I need to know? When do I need to know it? And where am I going to get this information? So I think this has been just a quick snippet in terms of, what to think about as you're developing a sustainability plan. And so I know that, unfortunately we're a little short on time. We have about 5 minutes left, so we have the ability to take some questions, although I've been trying to weave them in as we've been going along. And so I think we've been able to cover most of them. But if people have a question now that they want to try to type into the chat box, I'm going to try to take a couple that just came in. Would love to have the format you use for the payer and provider grid. So certainly we would be glad to share any of the tools that we talked about. If you're interested in anything that we talked about today, all of you know Joan, and so you can certainly email her and we can get that information back to you. So thank you for asking.
And Virna?
Yes.
You can hear me. That's good. So hi, everybody. This is Joan, and I am here. Sorry I was a little bit late. First of all, Virna, I wanted to thank you. And second, I just wanted to remind everybody that 2 weeks from today is part 2 of this webinar, so Virna is going to be back for more. And I also wanted to let you know that if you're one of those people who, like me, who thinks about your questions after the fact, Libby's going to be sending out a survey at the close of the webinar on SurveyMonkey that's going to be asking if you have additional questions. And if there are things you'd like to have addressed on the next webinar, that would also be, if you could add those, you'll see there's a question about that, because we want to make sure that these are worth your time, that they're valuable to you. I know for some of you this is easy, for others I know this is a stretch. So just want to make sure that this is accessible for everybody and helpful.
And that would be incredibly helpful if there are things in particular that you would like to talk about on the next webinar. Then it would be really helpful, because then we could do a deep dive, collect that information, and make sure that we address it. So please do that. Okay.
So thank you again, Virna. Thanks everybody for being on and for all of you hanging in here to the end, and have a great afternoon.
Thank you, everyone. It was a pleasure.